Well, good morning, everyone. I'm going to let everyone get settled in virtually here. I see a few more people are connecting to their audio, and I have disabled the waiting room. So if we have anyone joining a little bit after we begin, they'll be able to come right in. So let's let everyone get settled in. I was talking to Donna before we came on. She said I was complaining about it being, 22 below here with the wind chill. And then she informed me of the temperature up near you guys. And I felt even a little bit better. So thank you, Donna, for giving me some perspective on that.
Makes you feel warmer, doesn't it?
It really does. It's only the ambient temperature here is only -2. So that's kind of balmy compared to where you guys are at. So I want to just thank everyone. It looks like everyone's getting settled in here. It's great to see some familiar names and some faces as well. That's fine. Harold, we'll imagine you with your camera on, and we're just glad you're here. So thank you so much. My name is Steve Steiny. I am one of the managers here at the Native Center for Behavioral Health. I'm broadcasting to you live from the University of Iowa campus here at the College of Public Health. Our presenter today is in the beautiful state of Montana. I've been there recently, taught a course with Dr. Garcia. Gosh, it seems like it was forever ago, but it was just in November. So she's broadcasting to us from Montana. And then, of course, we have your very own Donna Enfield, who is up there in Bemidji country. And she'll say a few words here in a moment. But I want to welcome everyone to our sixth broadcast, our sixth session, our first of the new year. Today, Dr. Garcia will be sharing a lot of information about opioids, fentanyl, overdose, and working with our patients. So we're really happy to have all of you here this morning. I've just got a few introduction slides that I'll go through, and then I'll let Donna Enfield say a few words to all of you, and then we'll turn the floor over. So thank you so much for being here to join us for this sixth session this morning. This project is supported by the Native Center for Behavioral Health and the University of Iowa. The content of this event is developed by the presenter and does not necessarily express the opinions or views of the Native Center for Behavioral Health or the University of Iowa. Following today's event, we will make available to you a PDF version of today's presentation, including the slides. We are also recording this event and should be able to make available to you a recording of today's event. And lastly, if you are interested in receiving CEUs, we will be offering 1.5 continuing education units, either the substance abuse NADAC approved or the social work approved, University of Iowa social work approved CEUs. So you can let us know when you receive the follow-up email, whether you're interested in receiving a certificate for CEUs. I know we're gathered here virtually today, but we want to take time to acknowledge the land and pay respects to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Baer. Thank you. Well, at this time, I want to introduce our speaker, and then I'll turn the floor over to Donna to say good morning, and then we'll get started. Our speaker today is Avis Garcia. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. She is an LPC and an addictions therapist. She also has her PhD in counselor education and supervision with a specialty in substance use disorder treatment and working with Native Americans. Avis has a wide range of experiences working with various populations, both individual and group sessions. She is currently the director of a treatment facility there in Montana that I'm sure she'll mention a little bit more about. I'm really happy to have her on with us again for this session. She is my colleague and my friend and one of the consultants here at our center. So really happy to have you on, Avis, and good morning to everyone. I'm going to pull this screen down. And while I am getting up the next set of slides, I'm going to turn the floor over to Donna to say good morning.
There we go. Good morning, everybody. I'm going to keep this very short so that we can get going. It's just, I want to thank everybody for attending today. Grateful for this collaboration and for the opportunity to welcome Dr. Avis Garcia. I know, having heard her previous presentations, she is so knowledgeable and such a dynamic presenter, and we're just very pleased to have her and so glad all of you are here today. So welcome and happy New Year's, and on we go. Thank you.
Okay. Good morning, everyone. I'm here today to talk to you guys about opiates and treating opiate addiction and looking at how this is affecting Indian country across the country here. Before I get started, I want to let you all know that I am, can you go on ahead and forward the first slide?
Yes.
Sorry. I do a lot of research for these presentations, so I was pretty excited about doing this one. And I just like to let you guys know that I'm not a scientist. So there's some sections here where I'm trying to explain how the opiates affects our brains and managing pain signals. So I just thought I would put that out there before I get started. But today we're here because there is like a lack of training and research regarding addiction and its side effects in all substances. A lot of what I find when I do my research is mostly outdated. If it has today's date on it, the material that they're sharing in their articles is not current. So I tried to get as up to date as I possibly could, but then also found some really good information that was before COVID times. And we are also going to learn about helping chronic pain sufferers and understanding its impact in Indian country. We can go on ahead and move to the next slide.
Avis, can you see the full screen here? Is everyone seeing the full screen?
I can see the full screen.
Wonderful. Okay, just wanted to double check. Thank you.
Okay. To learn how to help chronic pain sufferers who have opiate addiction, people experience pain. It's estimated that almost 56% of the American population has experienced pain lasting longer than 3 months. And this is in 2006 alone. So as I said, a lot of the information that I find is dated, but to me, it was some very good information. The use of opiates has become widespread. According to SAMHSA, the National Survey of Drug Use and Health, estimates that enough opiate medication prescriptions are written, should say, each year to medicate every American adult every 4 hours for 1 month. So that is a lot of prescription medications that is going out. And these medications don't grow on trees, they're made in factories. So we can just imagine how many companies are busy producing these. It is estimated that 1/3 of chronic pain patients may have addictive disorders. By the late 1990s, a national survey of drug use estimates almost 70 million Americans have a prescription for opiate painkillers. To the next slide. What is pain? Pain is a neurobiological response to a noxious stimuli. In many ways, people are alike, but in many ways, people are different. Pain can be very different depending on variables such as psychology, emotional stress, and culture. Due to this, the definition is evolving. To the next slide. Okay, this is a picture of a bee and a hornet. And I was just thinking, do we know what pain hurts worse? We really don't know. As I stated, all of us are different and we all experience pain differently. I think my first experience with opiates personally was when I started having migraines, gosh, I can say 26 years ago now. And that was the first thing they gave me. And I can't remember how long I took them. I only took them when I needed them. But I had a really bad reaction with them. They called it a rebound effect. So it started to me, instead of helping me, it would help temporarily, and then I would get really sick. So I guess I could say my personal experience with and managing migraines has been, I've been able to see what the trends are personally of how I treated that specific issue. So we can go to the next slide. The history of pain and its treatment. Early points of view on pain, such as the early Egyptians and Greeks and early Romans, they looked at this as people had evil spirits in them. And I thought that was really interesting that this is what they thought of at that time. And so they were doing all these kinds of like trying to do whatever they could to help them because they thought maybe they were possessed by demons even. And so I was like, that was kind of interesting when you looked at the history. And then we have the early scientific points of view and the more modern take. You can switch to the next slide, Steve. Opioids is an opium-derived synthetic compounds used medically for the relief of pain. Many opioids have the potential for misuse. Opioids have been used and misused for thousands of years worldwide. Go to the next slide. The historical context of opioid use. Morphine entered into widespread use during the United States Civil War. Increased morphine use led to addiction among the upper social class. Increasing rates of addiction led to restrictive laws and policies which effectively criminalized addiction. The Harrison Narcotics Act of 1914 prohibited prescribing of narcotics, opioids to addicts. Physicians decreased prescribing for fear of prosecution. And that's in 1914. We go on to the next slide. In the 1990s and 2000s, strong emphasis on treatment of pain. Widespread belief that those with pain were less likely to abuse opioids. New potent opioids developed and were aggressively marketed. Supply of opioids increased markedly. Pain management standards became effective in January 1st of 2002. Simultaneously, the rates of addiction to opioids and death rates due to overdose also increased. Next. The development of opiates as the primary treatment of pain. In 1805, a pharmacist named Frederick Wilhelm Saturner began testing on a yellow-like crystal compound he produced by immersing opium in a heated ammonia solution. In his tests of this compound, he noted the psychiatric effects of euphoria, nausea, vomiting, constipation, and most importantly, decreased pain. By 1816, this compound became known as morphine. And as I was reading about this, it also talked about how he was testing this on his servants' children. So I was like, when we talk about ethics, those were his subjects. Morphine, along with the development of the hypodermic needle in 1853, became Western medicine's most effective scientific treatment for pain and chronic pain. So this was all about what's the best, quickest way to treat someone with pain. In the 19th century, morphine was one of the first medications developed. Due to this, it was frequently prescribed by doctors to treat many different medical conditions. And I had my migraines really bad and the medicine that they sent me home with didn't work. I would go into the clinic, yes, Indian Health Services on the Wind River Reservation, and this is what I would get, would be a morphine shot. That was in the early phases of my migraine problems that I've suffered with throughout my life. Then came the American Civil War. It's not known how many soldiers were prescribed opiates or developed addiction since health statistics weren't kept. The term soldier's disease is widely believed to translate as opiate addiction. In general, estimates range from 45,000 to as many as 4,000 Civil War veterans were addicted to opiates that were prescribed to them for pain management. Further, in his book, Opium Habit, published in 1868, Horace Day estimates 80,000 to 100,000 Americans are addicted to opium. So they didn't have the data that we have now. So this is just one person's opinion at that time, and that's pretty high at that time. Go to the next slide. Another interesting point, by 1872, it was known that morphine was highly addictive. Due to morphine's addictive nature, two new drugs were developed to replace it: heroin and codeine. A more modern point of view is to get a better theory of pain, understanding the depth of pain, understanding the use of opiates and their interaction with the body. Pain is a neurobiological response to a noxious stimulus. Typically, when we took classes in human anatomy or psychology, we learned a very simple explanation of pain, that humans feel pain because we possess specialized nerve cells called nociceptors, and noci means noxious. When these nociceptors were stimulated, you have a sensation of pain. Like when you stub your toe on the table or something like that, you feel that pain. Toward a better definition of pain, according to evolutionary psychology theory, pain is needed for survival. It's the part of our fight or flight response. The pain theory doesn't explain all pain, particularly chronic malignant pain. And then we have the psychology of pain next. To understand the depth of pain, when you first meet people for the first time in general, there's usually three things they share with you to get acquainted. They often want to know, what do you do for a living? If you're married, in a relationship, and if you have any children. So this is how we get to know people, but we don't ask them, do you have any pain? What kind of pain do you have? What do you do to manage your pain? You know, we don't have conversations about that to get to know someone. But as therapists, when we're doing our reviews and our intakes, this is probably something we need to consider. Understanding the depth of pain, chronic pain can interfere with all three areas of life and therefore also lead to a sense of loss of identity, depression, anxiety, and social isolation. Next. Culture and pain. Americans make up around 5% of the world's population, according to the US Census in 2010. So this is the world's population. Americans consumed 75% of all prescription drugs at that time produced on the planet, according to the National Institute of Drug Abuse survey. So that's Americans. The number of prescription medicine abusers in 2010 was 8.76 million. Next. Moving on to a better theory of pain, there is this gate control theory. And this is from Patrick Wall in 1965, asserts that non-painful neural input closes gates to painful neural input, which prevents pain sensations from traveling to the nervous system. Therefore, stimulation by non-noxious input is able to suppress pain. So if we switch to the next slide, when we say the non-noxious way to alleviate pain would be maybe we burn our finger or bump it on something and we hurt it, and so we might use our own hands to maybe squeeze it and hold it. So knowing that we can do something as little as that can help alleviate some of that pain. And on to a better theory of pain. Last year, I had knee surgery on my knee, and I was having a lot of pain before I went in. And I've always been one of those that when I come out of surgery, I swear I feel worse than when I went in. And I still have pain. So I've been continuing to go to the doctor and tell them, I thought the surgery was supposed to help. It's not, you know, it's help, but not as much. So their explanation to me was, well, it's not as bad as it was. So I was like, that's good. But I've learned when we talk about treatment, I'll share with you some of what I've been doing for myself. The better theory of pain is back up the peripheral or central sensitization. Pain itself often modifies the way the central nervous system works, so that a patient actually becomes more sensitive and gets more pain with less provocation. So it's just, I think being aware of that you have pain, you're more prone to be thinking that you have pain all the time. You can go on to the next slide. After all of that I just talked about, if we were in a group, I might take this time to have you guys chat with your neighbor and discuss what we've covered so far in regards to managing pain. And you know, it's not something we take a lot of thought in doing. And I have been working in the addiction field for 20 years now. And I remember my first year, like in an actual residential treatment facility, we all had about maybe 40 to 45 patients on any given day, and they probably still do where I was at. And what I learned is that a lot of people that were our opiate addiction patients, and mind you, I went into this field to help treat alcohol because that was mainly what was the problem that was being faced on the reservation where I come from at that time. And so helping someone with opiate addiction was pretty hard. These were our toughest patients. I mean, this is what I learned like immediately from the get-go, was these were our most difficult to treat patients. We can move to the next slide. The problem with most theories of pain is that they don't really explain all of the concerns presented by pain patients. And this comes down to too much chemical regulation and not enough self-regulation. So a lot of people are more willing to go to the doctor and want some medication for the pain, as opposed to what can they do for themselves to manage the pain on their own without having to go seek medication. That, I mean, medication always, any medication, if you watch TV, every prescription on TV has a long list of side effects that doesn't sound very pleasant at all. To the next slide. Going towards the better theory of pain, we evolve from pain as a neurobiological response to a noxious stimulus, to pain as a neurobiological, emotional, psychological, and cultural response to a noxious stimulus. So some of the adverse psychological effects of untreated pain is depression and anxiety, social isolation, sleep disturbances, suicidal ideation, a functional decline, disability, increased healthcare utilization and cost, morbidity and mortality, urinary incontinence, and pressure ulcers. Being a therapist, we often see clients willing to come in and talk about that they're having so much pain, and over the years, I've learned that there's oftentimes a lot of trauma that they've been holding and not haven't ever processed. So they're more willing to come and tell you what kind of pain they're having versus what else is going on. We can go on to the next slide. The primary treatment of pain, despite the evolving definition of pain, the treatment of pain is seen primarily as the use of opiate medication. Next. Understanding the use of opiates and their interaction with the body, drugs as chemicals can interact with the neural messaging system in three ways. Agonists are chemicals that can stimulate the nerves to better absorb neurotransmitters, or they can bond themselves with receptor sites for neurotransmitters. An antagonist is a chemical that stimulates nerves to inhibit the absorption of neurotransmitters. Lastly, drugs can delay or increase the reuptake of neurotransmitters in the synapse of the nerves, therefore decreasing the pain that's being felt by that individual that's using those. Understanding the use of opiates and their interaction with the body. When opiates are consumed, they act as an agonist within the nervous system. Specifically, opiates are able to bond with neurons at the mu opioid receptor related to their similar structure to natural occurring opioids, such as endorphins. So it releases the endorphins, which not only reduces the pain, but makes them feel better. Only opiates are better at stopping pain than your natural opiates. The next slide. Understanding the use of opiates and their interaction on the body. There are unintended consequences related to this body preference for artificial opiate use to control pain versus relying. Okay, sorry. I lost my spot here. One of these consequences are related to the analgesic effect seen in opioids. In general, the use of opioids as an analgesic, which is a pain reliever, even in the short term, 4 to 8 weeks, is shown to decrease the release and use of natural analgesic neurotransmitters. The result of this decreased release of natural analgesics leads to increased pain, which often leads to larger doses of opiate medications. So the tolerance starts to build. Another consequence is related to opiates bonding at the mu receptor. The result of stimulation of the mu receptor leads to activation of the midbrain reward pathway. Activation of this pathway activates the ventral tegmental area, the VTA, which then triggers a release of the neurotransmitter called dopamine, DA, in an organ of the brain called the nucleus accumbens. The end result of this process is an emotion of energizing pleasure. This emotion, combined with the process of associative learning to cope with strong emotions, people, places, and situations, can lead to the development of cravings for opiate medications. And a lot of my heroin users that I've worked with in the past, I want to say 90 to 95% of them told me that their addiction to heroin started with taking mom's pain pills. Mom had surgery and they were teenagers and thought to see what the pills felt like. Understanding the depth of pain. Remember that pain is a physical, emotional, psychological, and cultural concern. We focus too much on treating physical concerns and not enough on treating the whole problem with pain. Next. That's why we are in the second American opiate epidemic. So if you look at this chart on the left-hand side, drugs involved in overdose deaths in 1999 to 2017, getting a little more current, as you can see the line here on this graph goes up. We have the National Survey of Drug Use and Health estimates that over 100 million Americans have prescriptions for opiates. It's estimated that as many as 1/3 of chronic patients have addictive disorders. Drugs involved in US overdose deaths, among the more than 72,000 drug overdose deaths estimated in 2017. The sharpest increase occurred among deaths related to fentanyl and fentanyl analogs, synthetic opioids, with nearly 30,000 overdose deaths. And I do know a lot of what I was reading that's most current is since the COVID has hit, this has gone up as much as 30%. So if that says anything about how this is affecting our population during this time. Next slide. Cost to the system. 130 people in the United States die from opioid overdosing daily. So this is every day somebody is dying from opioid overdose. The Centers for Disease Control and Prevention estimates that the total economic burden of prescription opioid misuse alone in the United States is $78.5 billion a year, including the costs of healthcare, lost productivity, addiction treatment, and criminal justice involvement. Next. More cost to the system, looking at the big pharma role. In 1990s, pharmaceutical companies tell medical community prescription opioid pain relievers are not addicting when prescribed for pain. 2017, more than 47,000 Americans died from opioid overdose. Prescription opioids, heroin, and illicitly manufactured fentanyl. In 2017, 1.7 million people in the United States suffered from prescription opioid substance use disorders. In 2017, 652,000 suffered from heroin use disorder. So the heroin is cheaper than getting the pills when they can no longer get that prescription. And most of the major cities is where the highest heroin problems are. So there are pockets of high abuse in the United States. Next slide. Just the facts. 21 to 29% of patients prescribed opioids for chronic pain misuse them. 8 to 12% develop an opioid use disorder. 4 to 6% who misuse prescription opioids transition to heroin. 80% who use heroin first, they first misuse prescription opioids. 30% increase in opioid overdoses from July 16 to September 2017 for 52 areas in 45 states. And as I said, the most current information that I read that this has gone up during this COVID period. 70% increase in opioid overdoses in the Midwest region, July 2016 to September 2017. And off and on throughout my career, over I want to say the last 5-6 years, there are a lot of documentaries on TV now that you can watch. And most of them that I've watched are in that Midwest region. And it looks, I didn't see them showing Native Americans and what I was seeing. I was seeing the Caucasian population and the very young people. So my understanding of the ages affected seems to be the same age as the suicide rates, that 18 to 25 window. 54% increase in opioid overdose in large in 16 states. So that's a huge increase. Next. So what should a healthcare provider do? Is it better to treat pain or is it better to treat addiction? We're all addicted to something that takes the pain away. The next slide. What is addiction use disorder? What is dependence and why is it important to understand the difference? Understanding dependence versus understanding addiction. The next slide. Dependence is a state in which an organism functions normally only in the presence of a drug, manifested as a physical dependence when the drug is removed and there are withdrawal side effects. Next. Understanding dependence. In general, the use of opioids as an analgesic, even in the short term for 4 to 8 weeks, is shown to decrease release and use of natural analgesic transmitters. Remember that treatment goals for dependence are very different than treatment goals for addiction. What is dependence? Withdrawal symptoms are varied depending on the drug used. With opiates, in as little as 4 to 8 weeks, their use can lead to depletion of natural endorphins and androgen. Next. Endorphins are used to control pain in your body, and they are used to control stress in your brain. Androgen is used to help give you energy and sex drives. Due to decreased endorphin and androgen production in withdrawal from opiates experience, there is an uncontrolled stress and anxiety, and related to this is poor sleep and eating, lack of energy, poor sex drive, and even depression. Most importantly, incredible debilitating pain. So it's like they get worse than they were to begin with. Dependence, due to severe withdrawal symptoms, they crave opiate, and without intervention, they will return to use. That's with most substances, there is those side effects that people face. A more modern view of addiction, it's a brain disease. People tend to get addicted to things that trigger a tidal wave of neurotransmitter called dopamine. Overuse of dopamine leads to decreased reception in neurons. Because of poor dopamine receptors by the neurons brought on by the long-term exposure to dopamine due to addiction, brain function is impacted by decreased pleasure when using drugs, decreased motivation, poor memory, poor decision-making, and poor impulse control. Next. Understanding addiction. Have you ever had nuts such as almonds, walnuts, and pecans, fruit, meat, beef, chicken, and fish, candy, chocolate, sugar, and ice cream, and coffee, tea, milk? Like, I cannot start my day without my coffee. And when I'm told I can't have my coffee, it's like, I used to be like, oh my God, I can quit anything, but I can't give up my coffee. And now I tell people when I have to go without it, I can go without it, because sometimes at my age, we have to get regular checkups. And part of that will involve not having anything to eat or drink, which will include caffeine. Testing brain circuits involved, or targeting brain circuits involved in addiction. So if you look at this diagram on the right side, which is the brain, the new knowledge about which parts of the brain are involved in drug abuse and addiction has revealed new targets for medications development. These medications aim to interfere with the drug's reinforcing effects. So this is the reward center, increasing the of natural rewards right around here, and strengthen executive function, inhibitory control, interfere with conditioning, creating new memories, and counteract stress responses that leads to relapse. You can go to the next slide. Understanding addiction. Factor 1, DNA and surge of dopamine. There is a tremendous difference in the amount of dopamine released by different foods and behaviors. So again, doing research on alternatives to helping people manage pain. When I was talking about the foods, almonds are good for you, bananas are good for you. Like a lot of the natural organic foods are really good for helping people to control pain, and even for some depression and anxiety as well. It's having a healthy diet. Factor 2 is how often do you need the surge of dopamine? When this happens frequently, the neurons that make up the brain will shut down, receptor sites for dopamine. Next slide. Understanding addiction concerning factor 2, reasons to engage in addictive behavior a lot, depression, anxiety, dysfunctional relationships, and pain. So this is people choosing to take prescription opioids, are manufactured off the street opioids, because they don't think of what they can do to manage pain, how to reduce stress in their day-to-day life, and how to manage their depression without using any kind of medication. So learn coping skills, like about coping skills in my work. Next. Activation of the midbrain reward pathway. Activation of this pathway activates the ventral tegmental area, which then triggers a release of the neurotransmitter called dopamine in an organ of the brain called the nucleus accumbens. The end result of this process is an emotion of energizing pleasure. This emotion, combined with the process of associative learning to cope with strong emotions, people, places, and situations, can lead to the development of cravings for opioid medications. Next. The definition of addiction from ASAM is a primary neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. Addiction is characterized by behaviors that one or more of the following: impaired control over drug use, compulsive use, and continued use despite harm and craving. Next. In this review so far, pain is a survival response that has evolved in humans for over 500,000 years. Early theories concerning pain tended to look for spiritual. By the 17th century, through scientific inquiry, pain is seen as caused by specialized cells called nerves and treated with morphine. The widespread use of morphine led to the use of the first American opiate crisis. And again, there is a difference between dependence and addiction disorder. Next. Pain, particularly chronic pain, can be a very deep and troubling disorder that impacts people physically, emotionally, mentally, culturally, and spiritually. Use of opiate medications to treat physical pain has led to widespread dependence and addiction to these drugs. Addiction is a pervasive brain disease brought on by massive release of dopamine. Frequent releases of dopamine alter neurochemical reception of dopamine, leading to decreased functioning of the brain, particularly the reward and memory learning, motivation, inhibition, and executive function, executive decision. Further, we are using outdated treatment models that haven't kept pace with the current trends and research regarding addiction. Next. What changes should we respond to? Remember that change and recovery is a process, not an event. So as you can see, it's an up and down. I did a presentation yesterday and I talked about addiction and treatment, this up and down, that there's no straight or no straight up improvement. You know, it is a difficult and challenging process, and it's hard work. That's, you know, why we're all here. We're all here to help people in understanding that it's never anything easy. I very rarely see somebody come in and just do really well and it's smooth sailing through the recovery process. It doesn't work like that. Next. The changes we should be responsive to is the physical health, intensive pain intervention, complementary and alternative medicine. And the programs that I oversee are accredited by CARF. And one of their requirements that we do now as counselors is to provide patients with complementary and alternative medicine options to help them learn how to manage pain without relying so much on prescription medications, doing some counseling and alternative medications, which we'll talk more about as we continue. Next. A lot of our physical health, exercise and stretching, and what we eat and getting sleep, all of this is very important to our ability to manage pain and manage stress. Go to the next slide. Exercising and stretching should be done through a physical therapist. Physical activity helps your body to release endorphins, decrease stress, and decrease inflammation. And I recently, well, before the New Year's, I started going to a gym and taking some classes. And I think the best part of the class is the end when we stretch. And I was like, man, I can't believe, you know, how simple these little stretches that we're doing feel so good. So it's something as simple as getting a mat on the floor, and you can Google stretches that you can do that are really helpful. Next. Next. Physical therapy is an important role in the pain management of pain. Stretching exercises can lead to more stamina, greater flexibility, speedier recovery, and a brighter mood. The increased activity along with the improved mood can speed recovery, improve quality of life, and reduce pain. Typically, patients need 8 to 12 sessions over a 4 to 6 week period to get started. It has frequently been my experience that patients fail to follow through on doing exercises when they complete physical therapy. So when they're done with physical therapy, it's just like treatment, you're not done. You have to continue to do the stretches and the exercises for yourself. It's not something that's just done. It's like recovery. That's why we have continuing care, because once they finish outpatient, it's not, you're done. It's okay, now we can step you down a little bit, but we have to continue the process. It's necessary that healthcare providers act as good case managers and follow up with patients about the need to continue and exercises when physical therapy is complete. And back on the reservation, the Wind River Reservation, where I come from, I have gone to physical therapy there. I was in a very bad car accident when I was really young, and it's come back to haunt me in my later years in life. And that was one of the things that they have recently incorporated on the Wind River Reservation Indian Health Services is physical therapy. And I think it's really awesome. That was never there when I first started to feel the pains that I've had to deal with from my car wreck I had several years ago. Next. Chiropractors. The goal of chiropractic treatment is to increase movement in the joint and relax the muscles. Some chiropractors use heat, electrical stimulation, or ultrasound to help relax your muscles before doing spinal manipulation. And I know some people who swear this is their go-to. Next. And here's some examples of some stretches that you can do. Make stretching a daily routine. Hamstring stretch, camelback stretch, trunk rotation. I saw briefly somebody's chat comment popped up of yoga, and I haven't done yoga yet, but it's always one of them things I say that I'm going to do. And I know people that do it just because they like to do it. And so any form of stretching be helpful. Next. We're talking about our diet and what we're eating. Herbs and vitamins, anti-inflammatory herbs such as turmeric and ginger can be as effective as an aspirin, increasing swelling and pain according to some studies. Food that increase swelling: sugar, fat, vegetable oil, carbohydrates, alcohol, and processed meats. All of that can only serve to increase your pain. And so they say, what you eat is how you feel. So if you eat crap, you're going to feel like crap. Yeah. So it's only going to be any kind of pain. Next. So for it, if you look to the top, the right-hand side, these are the foods you want to eat. There is some beef in the picture to have lean, cucumbers, organic. I like no longer use vegetable. I use olive oil a lot, and I've learned that there's all different flavors of olive oil. So I've been using that much more the last few years. Carbohydrates. We got to watch those. We completely eliminate them. It's just using those in moderation. Next. Eat foods that will help put dopamine in your brain. Of course, the sugar, salt, and animal fat does all that. That's why there is an obesity problem. Some people, I look at food as an addiction for some people, that they may be struggling with some pain or some emotional pain, and they choose to overindulge in those because it really does release dopamine in your brain. But you want to pick the best things, such as milk and cheese and yogurt, unprocessed meats, such as beef, chicken, and turkey. Like I said, I get migraines, so if I can have unprocessed meat, that is better. Wild game, all us natives that like to hunt, and fish, all that natural stuff, that's what's good for us. Buffalo, eggs, fruit and vegetables, especially, like I said, bananas and nuts, such as almonds and walnuts. And I think it's like 10 almonds a day is like recommended. And dark chocolate. Like if you want to have some chocolate, have some dark chocolate. It really does release dopamine to help you feel better. Next. It's important to get a good night's sleep. What happens if you don't sleep well? Personally, having had migraines for as many years as I have had, I've learned that my sleep is very important to my managing my migraines. If you don't sleep well, you get sick, you have an increased risk of colds, heart disease, or cancer. Non-REM is important to heal damaged cells. You can't think. REM sleep is important for your memory, so that recharges your brain. Increased stress, which can lead to more pain or drug use. So you don't sleep well, you're not going to feel well. And so, of course, there are those that tend to self-medicate with things that aren't healthy for them either. Next. As I said, a good night's sleep is a therapist's secret weapon in the long-term management of pain and addiction. So it's also important to help our clients learn to find some ways to help themselves to get better rest. A lot of our users in the community don't have jobs. They don't have a regular schedule like most of us do that work Monday usually. So it's helping them learn how to create a schedule that is more effective for their overall health and pain management as well. Next. More on sleep. It is good to have good sleep hygiene, set up good biorhythms by setting a bedtime. I read that even off, you should try to keep the same hours or you can totally mess up your sleep cycles. Sleep cycles are 90 minutes long, and you need to have a minimum of 5 a night. Your sleep environment needs to be dark so that your pineal gland can make melatonin. Your sleep environment needs to have an air temperature between 62 and 68 degrees. So when you get a good night's sleep, it helps your heart to be healthy, may prevent cancer, reduce stress, reduces pain, makes you more alert, bolsters your memory, can help you lose weight. I read recently that I didn't even know that sleep was a part of helping to lose weight. And naps make you smarter, may reduce the risk for depression, and helps the body to make repairs. I'm being notified that my time is going, so if I seem like I'm going a little fast, it's just because of the time limit here. I wasn't aware of that. Go ahead and move to the next slide. The intensive pain intervention, there's this new thing called dry needling, surgeries, and electrical stimulation. Next. Dry needling is the injection of local anesthetics and steroids into pain sites. Next. There are surgeries that are expensive and a coin flip if they work. About 1 out of 10 develop addiction to post-pain surgery medications. So that I was having some bad knee pain, had surgery, it helped, but it hasn't made the pain go away as much as I thought it would. Electrical stimulation, the TENS units, these have been out for a long time and I've been used mainly with the elderly population. And over the years, I've encountered people that can't take opiates. It's probably good for them, but they've had to have surgery that puts electrical stimulation, actually puts it into their body now and runs it through their spine. And from what I know, the people that I've met that actually have those say that they really work. So these trigger endorphin release, this pain, no medication involved. Next. Complementary and alternative medicine can, again, like I said, this is what CARF requires us to share with our patients and ask them questions about. These are pain strategies that are not traditional in the education of treating pain for healthcare professionals because they are not traditional medical services. Typically, insurance doesn't always have to pay for them. Further scientific efficacy research is, I should say, sparse at best, sorry. Popular chems are massage and vibrations therapy, acupuncture. I love acupuncture. It's really helped me a lot with my migraines and my sleep. Heat and cold therapy. I've learned through all of the knee pain I've had in the past year. That is amazing. All I need to do is get the ice packs out and put it on my knee, and it helps with the pain almost immediately. And then there's braces and supports. If I'm going to go to the gym, the doctor gave me a brace that I strap on and I don't have it, that it's something that I have to have. Next. Massage and vibrations therapy. At least once a month for self-care, I do massage, but I initially started doing this for migraines because I had a friend who is a massage therapist and asked me, had I thought about using massage to help me with my migraines? And at that time I was like, I would never spend money like that on myself. And now I say it's the best money I can spend on myself. So almost a quarter of all adults had at least one massage in the previous year. They choose from among many massage styles. So there are different types of massage styles. The usually ask you what you want, or they have a menu. So you have to ask questions to understand what they are, because some of them actually, yeah, can leave. I've done the tissue and I'll get bruised and I'll feel good for days after that. Next is acupuncture. When I was going to school at the University of Wyoming, getting my PhD, I'm trying to think how many years ago that was now. They had some students come in, and they still do free acupuncture because they're always training people that want to get the certification in acupuncture there. So they have this free clinic that runs like every Saturday, and whoever wants free acupuncture, you just have to show up. And that was my first experience with acupuncture. And I want to say it is amazing. I love all of these, but I haven't had a chance to find out where it's done here in Montana, where I'm living now. Next. As I was saying, heat and cold therapy is the best. I found that ice is probably the best thing ever. Like I said, that knee surgery I had, it didn't make my pain go away, but I learned from that experience that if my knee is hurting a little bit, I want to get some ice out and put it on there. Next. About the braces and supports. Mine doesn't look like that, but mine is Velcro that straps on. It helps a lot. Next. What about counseling? What about all of us that are counselors? I've had needed, so being an active listener, all those basic skills that you need to have to be an effective counselor, that's what a lot of people are needing. Next. Remember that pain in the neural matrix model is a physical, emotional, psychological, and cultural response. Due to this pain, be treated successfully with counseling. In particular, it can be treated with cognitive behavioral therapies, such as eye movement desensitization and reprocessing, the Emdr, and mindfulness-based reduction. Substance use disorders are also best treated with CBT, medication-assisted therapy, and tapering programs. However, while it's easy to who are familiar with CBT, it can be difficult to find a therapist who specializes in treating chronic pain and addiction. Also, no one wants to go to therapy. Next. Counseling basics for addiction and pain, help patients to reduce stress, challenge their beliefs about an addiction, involve them, develop management or addiction plan, and encourage them. So those are the basics for addiction and pain. Counseling, best way to reduce stress is breathing exercises. Do them myself, they're very helpful. The next one is meditation. And those of us that are native, I really look at the sweat lodge as a form of meditation. I mean, I take all my problems and all my worries, whatever is on my plate that's bothering me, and I take it there, you know, just praying about it is a form of meditation that's really helpful. Next, the EMDR. As I was saying, some people that have a lot of pain, if you get to know them a little better, you may discover that there's some trauma there that needs to be dealt with. And EMDR is proven effective for the most part. But again, everybody's different. So not everyone responds to this as we might think they would. Then the mindfulness-based stress reduction. It's a standardized form of meditation and yoga, trains people to reduce their perceived level of stress by self-regulating arousal to stressful situations or symptoms, and has been shown to be effective. So those of you that are therapists and counselors, there's tons of books out there now on Amazon that are like, I tell people it's like $20, but there's a lot of good activities that you can work with your patients and teach them to do this for themselves. The next is family counseling. Help them learn to say no, renegotiate the role in their family, and put you and your pain and addiction first. A lot of families I know in my years of working is they see the person who's struggling with the addiction as the one that needs to get fixed, and not looking at the whole family context of what might be contributing to that person's addiction issues. Next. The medication-assisted treatment and taper programs are basically outpatient detox programs. MAT programs slowly wean or taper patients off the medicines that are prescribed to curb patients' cravings. To use drug MAT programs offset local government spending by $1 to $7 ratio. In other words, for every dollar spent on MAT, decreasing spending on healthcare and law enforcement by 7. So look at it that way. Basic tapering rules: when patients aren't stressed, they can taper them. The longer the taper, the more successful. It may take up to 5 years, so it's not something that's done quickly. And most patients will stay on a small dose to maintain their recovery. Next. Counseling works to control pain and addiction. So why don't people go? They think it's too time consuming, that it costs too much. They might feel ashamed or guilty. And then there is the cultural stigma. Those of us that are fortunate to have Indian health services, behavioral health services, we have that. And being that I'm duly licensed where I'm at, we have patients that do come and they don't, it's interesting, they don't want to go to behavioral health. They want to come to us, and we're like, we have a parking lot in the back behind our building and they choose to park there. So we were just talking about how they don't want to be seen that they're there. So where if they go to the clinic, the parking lot is more big and open, but we're out of the way. So I've got to talk to Dr. Chapman about that. Next, alternative medications. Since medical doctors are less willing to write long-term opiate prescriptions now, there is a strong need for alternative medicines to manage pain and strong pain sufferers. Popular alternative medications are NSAIDs, selective serotonin uptake inhibitors, selective norepinephrine reuptake inhibitors, and anticonvulsants. Experimental medications, There is also marijuana and CBD oil. I have been here in Montana since the end of June, and when I got here, there is medically prescribed surgeries here for pain. And although I still have mixed feelings about it, I do see people that might be taking opiates are using the CBD and marijuana. Next. Use of antidepressants has been used. They work to control pain, such as helping regulate the emotions, most effective in treating about brain damage. It should be noted that SSRIs and SNRIs may take up to 8 weeks to work. So these patients that are taking them might not feel anything for a while. And most people want something that works instantly, like the opioids. Next is the anticonvulsants, such as gabapentin. And I do know where I come from that these have been abused as well. I see a lot of people that are on those. I'm looking at the time that is running down, so I am going to flip through some slides here. This just talks about the alternatives we have, the anti-steroidal, anti-inflammatory drugs, ibuprofen, experimental medications into the future. So research continues to be done, working. The G protein coupled receptors binds chemicals to cell and communicates the presence of these chemicals to the G protein, which then triggers the release of other chemicals as a response. The kappa opioid receptor, which is associated with pain, but also depression, anxiousness, and mental processing. So this is works on the selective opioid receptor. The high voltage gated sodium channel, they control the action potential of neurons. So by control of action potential prevents pain messages and related to chronic pain. So that's actually salt. The nerve growth factor levels are higher in people with chronic pain. So scientists theorize by blocking this factor, pain can be reduced. So research that continues discovering newer things. Next, the GPR 139, according to Scripps research, it's a G protein coupled receptor. When the GPR 139 receptor is removed via gene editing the neurons from neurons in mice, it counteracted the effects of opioids in neuronal firing. In other words, there's no withdrawal from opioids with that. Talking about marijuana and CBD oil, it's been really popular. I have a friend who relocated to Colorado, and actually her whole business is based on the CBD oils and creams and ointments that she says helps her a great deal. Next slide. However, there's very little research available on the effect of it. The Wealth Organization in 2017 reported CBD appears to not have abuse potential or cause harm for people. The Food and Drug Administration approved GW Pharmaceuticals Epidiolex, a CBD oil for use to treat seizure disorders. And outside of this, there is little research to marijuana being a Schedule I drug, but like a lot of places are legalizing marijuana now, and a lot of people say that they're using it for pain. And when I was in Wyoming, it was in Colorado because I was working in Cheyenne, so we often had a lot of patients that were being sent in for all of the use in Colorado right next door. What is CBD oil and how is it different from marijuana? CBD oil is produced from the hemp plant versus the marijuana plant. Due to being made from hemp plant, It is very low in THC content. It says typically under 3%. How does it work? You have two cannabinoid receptors on the neuron called CB1 and CB2. The CB1 receptor is involved in mood, emotions, pain, movement, and coordination, memory, appetite, and thinking. The CB2 receptor is involved in the immune system, pain, and inflammation. So it works on both of these. This is where it gets confusing. CBD oil controls chronic pain. CBD oil helps to quit smoking. CBD oil helps to control withdrawal symptoms, but I can't find any research that confirms these claims. The confusion continues. CBD only covers the CBD1 receptor. Due to this, California Public Medical Center in San Francisco claims that CBD oil must be used with THC to cover both the CB1 and CB2 receptors. This is referred to as the entourage effect, to lead their pain control, and there's no citation. Like I said, there's no substantial that finds how effective this is. So the route of entry of CBD oil also seems to affect effectiveness. So smoking or vaping works better for acute pain. Edibles and ointments work better for chronic pain. Start with a low dose and build so you don't feel pain. Don't discontinue any prescribed medications. So if you're taking any other medications, you don't want to stop taking those unless you're under doctor's care. Because of a lack of science, the effects of CBD and THC not known. Side effects of CBD and THC not known. We may very well be looking at a placebo effect. That's what some people believe. So might just think, oh, it really works, and it really does. So, hey, if it works that way, then I think they should give it a try. Overdose deaths among American Indians. There's a misclassification in one study that I read on American Indian and Alaska Natives, saying that there is an underestimated drug overdose mortality rates, and that is because of death records and how they're reported. I requested some data and I still haven't received it. I was hoping to have received that data by now that covers Wyoming and Montana on the opioid overdoses. Coming from the Wind River Reservation, I have, people talk about what's going on, and there have been some recent on our reservation of some very young people, and there is some dangerous synthetic fentanyl being distributed out there, and some of these young people that don't know what they're getting their hands on is very dangerous. The cause of death record that is usually noted is accidental poisoning by exposure to drugs, assault by drugs, intentional self-poisoning by an exposure to drugs, or poisoning by an exposure to drugs. And then this next part just talks about the ICD codes that are listed as cause of death. Next slide. Native Americans, as with every social problem we have, we seem to get hit the worst by everything that is problematic in society. The death certificates say they died of an overdose, but that's not right, one member of their study group said. These deaths were a culmination of far more than that. Despite their resilience, Native Americans carry in their blood 500 years worth of pain from being robbed of their land, their language, their culture, their children, and living people's memory. Children were taken from their families and sent to boarding schools with the motto to kill the Indian and save the man. What they died of is a broken heart. Some more statistics of Americans. In 2018, 11% of American Indian and Alaska Native population battled substance use disorder. The most drug used in the American population is marijuana, followed by non-medical use of prescription drugs. They're selling them on the streets. And I've been hearing like how much money they're worth from people that come into our program. And I'm like, it's, and the other thing is the law enforcement doesn't seem to be doing much right now because of this COVID situation. So it's created this double problem of we have these people using drugs, not just pills, and the law enforcement system doesn't seem to have the ability to do what it did prior to COVID. Cocaine, hallucinogens, inhalants, and heroin. Native American youth are particularly at risk for substance abuse, with studies showing that Native American children, 8th, 10th, and 12th grades living on or near reservations have a higher incidence of lifetime and past 30-day use of cigarettes, alcohol, marijuana, and other illicit drugs than a national sample of American youth. I wanted to share some news. This is outdated news, but one is more current. In 2005, on the Wind River Reservation, where I come from, several people were arrested on drug charges, and one of them was one of our tribal court judges. She was charged with the distribution of prescription drugs. And this, during this time period, was probably when most people could walk into the clinic and get pills for just about anything. And now, because of that, it's really changed how things are working clinic, and I'm glad that the clinic is responding to that. Like I said, physical therapy is now made available to people. Next slide. As I was doing some of my research, trying to find more current information, this is in Oklahoma. It says they were hit by pain pills. It's hitting Indian country everywhere. And the next slide. There is the non-medical use of prescription drugs. Abuse of pharmaceutical medications, including sedatives and prescription painkillers, is high among the entire United States population. Community, just over 5% report misuse of prescription drugs in 2019. Native American youth ages 12 to 17 abuse prescription medications at double the rate of the American adolescent population. Some statistics on prescription opioid medication among American Indian population includes hydrocodone and oxycodone as most widely abused prescription painkillers. In 2001, opioid overdose deaths increased at a more rapid rate. New study in New Mexico Native High School found that 1 out of every 10 students misused a prescription painkiller within the month. Opioid overdose rates in 2017 were the second highest in the United States, with the exceptions of the 12 to 17 age group showed decreased prescription misuse between 18 and 19. COVID-19 and opioids has worsened the opioid crisis. Estimated overdose rates increased 22% from July 19 to July 20. American Indians have the highest overdose rate. And the next couple of slides, due to the lack of time, is just going to show you the research that I found that shows that natives have the highest overdose death rates. You can switch to those next few slides. So as you can see, American Indians total drug is at the top. American Indians with opioids, these are overdose deaths. American Indians with heroin is this top one here. The next slide, overdose deaths by race. And the American Indian, this is our color right here. We go all, look, we're all up here, we're up here, and all the other races are down here. And that wraps it up for that. I just wanted, to take a little time to talk about it briefly. The most of the research that I did find for Native Americans and opiates was pretty similar at everything else that I looked at. And you know, I'm just, like I said, I'm waiting for that data that I requested, and I thought I would have it by now and I don't. So I apologize that I don't have that. Maybe at a later date, I'll be able to share that information via email. If you're on our listserv, I can ask that it be sent out, because I really wanted to get a good look. I run a tribal opioid response grant for the Crow tribe as part of my running the Crow recovery program here in Crow Agency, Montana. And I want to say the biggest two problems I'm seeing here is alcohol and methamphetamine. We do have some opioid people, but I don't think they're coming in and getting help. I mean, we hear talk, but I don't see them actually coming in. I think the ones that actually show up are the ones that we get drug tested. So the tribe does drug test its employees, and you know, we have a little system that sends them our way to get counseling so that they can keep their jobs and hopefully stop using substances if they're not prescribed them. And that is about it. That was a lot of material to share. I hope you got some helpful information out of this. I appreciate each and every one of you for taking time out of your schedule to be here and attend the presentation today.
Well, thank you so much, Avis. And I know Donna had to step off right at the top of the hour. We are at the top of the hour as well. If you have some questions or would like some comments to follow up on, feel free to email me here at the center, and I can forward those on to Avis. I'm just going to put my email in the chat if you want to grab that, if you don't have that already. Happy to forward any information on to Dr. Garcia, and we really do appreciate everyone. We'll follow up with you in an email, provide these slides in a PDF format, and then if you're interested in some CEUs at that time, you can also let us know when you receive that follow-up email if you're interested in, and just specify whether you'd like social work or the substance abuse CEUs, and we'll make sure we get those out to you via email. Thank you again, Avis. It's great to have you on, and really appreciated all that information. And thanks to each and every one of you for joining us this morning. Have a great rest of the week. And until next time, we'll broadcast again in February. So I hope you can join us. We'll have another great topic to review. I think it's reducing stigma and addressing stigma. So that will be a really important topic to have a discussion on. So anyway, thank you, everyone. Until next time, stay safe, stay connected, and stay healthy. Take care.